Hello, I'm John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital. Welcome to Key Insights from Great Debates in Hematologic Malignancies. I am one of the co-chairs of this meeting, and it's really been a great event. So I want to give you over the next few minutes just a few highlights from some of the things that we discussed and were part of the session. We've had some great overviews of key topics in lymphoma, as well as some debates about some of the issues that physicians really and their patients face in practice. So one of the discussions was from Peter Martin from Weill Cornell Medicine, who talked about new drugs in follicular lymphoma. As you know, follicular lymphoma is the second most common type of lymphoma, really the most common indolent type of lymphoma. And so these patients are managed over many years. 80% of them don't die of their disease, they die with their disease. And so the novel agents that these patients will receive over time continues to evolve. And so Peter has given us an overview of some new data regarding advances in follicular lymphoma. This includes what's new and what's happening with novel anti-CD20 antibodies like obinutuzumab, lenalidomide. We have some new data coming along in various studies with that agent. We have PI3 kinase inhibitors. Idelalisib is approved. Copanlisib is now approved. And then we have drugs and regimens that have been around for a while, including bendamustine and other agents, certainly R-CHOP is an example. And so there's a lot happening in follicular lymphoma, a lot of new drugs. Other PI3 kinase inhibitors as well are coming along. Novel antibody drug conjugates, bispecific antibodies, a lot of new data there. So Peter gave us really a great overview to bring us up to date. The major unmet medical need in follicular lymphoma is that group of patients that has an early progression within 2 years after their frontline therapy. Data show that that is the group of patients that is at higher risk. That's a group of patients that, unlike the 80% who have long first remissions and have essentially a normal life expectancy, the 20% that progress within 2 years have an unfavorable or less favorable life expectancy and are more prone to die of their lymphoma. So clearly, trying to figure out how best to treat those patients is a critical piece of information. So our debate on this topic really centered around what is the best approach. And so we had Greg Nowakowski from Mayo Clinic talk about novel drugs, and some of the drugs I mentioned before were on that list. And he debated Koen Van Bezian from Weill Cornell, who talked a bit about how we should consider transplant approaches. And I think really that is one of the fundamental questions, I think, in follicular lymphoma, because again, the highest risk group of patients really is the group that needs new therapies, where our choice of therapy matters the most. We have some cooperative group studies that are looking at this issue, but I think in a practical terms, a patient who's relatively young, do you continue to give them new therapies and cycle through agents, or do you move to an auto or allo transplant? So we had a really great debate on that topic. Moving to diffuse large B-cell lymphoma, the most common type of lymphoma, the most common of aggressive lymphomas as well. We had Sarah Rutherford from Weill Cornell give us a bit of an overview on which patients should get something other than R-CHOP therapy. R-CHOP is a standard therapy for diffuse large B-cell lymphoma. We've had some randomized trials that have essentially largely confirmed that. There have been a number of new advances in diffuse large B-cell lymphoma in understanding the biology, but thus far we are relatively limited in being able to figure out turning those advances into new therapies and better outcomes. So Sarah gave us an overview on the issues around double hit lymphomas, where we may use something other than R-CHOP, double expressor lymphomas, where we seem to continue to use R-CHOP, and then the primary mediastinal lymphomas, where we tend to use the dose-adjusted or EPOCH regimen, as well as a number of other lymphoma situations, particularly issues around CNS prophylaxis and other scenarios where there's some nuances to the discussion. And so I think this was a great overview of the most common type of lymphoma that people face in practice, and being able to say, well, when What cases do I use a standard therapy R-CHOP? Which cases do I move on to something else or tweak the regimen? And given that most of these patients are cured, obviously for people in practice, this is an essential set of information to know, because ultimately you'll encounter these patients and obviously want to give them the best outcome possible. Also focusing on diffuse large B-cell lymphoma, we had a spirited debate around the use of CAR T-cells and the value of CAR T-cells in diffuse large B-cell lymphoma. As you know, CAR T-cells are now available for ALL and for diffuse large B-cell lymphoma. It's a very exciting area. Patients have a lot of questions. I can tell you every single clinic day someone tells me, and I'm sure with you as well, you know, should I get CAR T-cells? What's going on with CAR T-cells? And so certainly, even if relatively few patients are appropriate candidates, we all need to know kind of who we should be thinking about this and who it's not the appropriate therapy, at least at this point, for. So we had a great debate. Jeremy Abramson from Mass General talked about the advantages and the impact of CAR T-cells. I talked about the limitations of CAR T-cells, and we had a nice back and forth around the value at this point in time. Obviously, this is a rapidly changing field, a lot of new data coming along, and the important thing obviously is for practitioners to stay tuned and keep an eye on the relevant information, because again, that's going to continue to go and impact our practice. Finally, our last debate was around Hodgkin lymphoma and the use of brentuximab vedotin, the antibody drug conjugate directed against CD30, as part of initial therapy. We had an important study presented in 2017 at the ASH meeting in the plenary session, randomized trial of ABVD versus ABV, or brentuximab vedotin, substituting for bleomycin in the ABVD regimen, that showed a progression-free survival benefit but not an overall survival benefit. And I would say in my discussions with the lymphoma community and my colleagues, we have a lot of debate as to whether or not brentuximab vedotin should be included as part of upfront therapy at this point, or given the lack of an overall survival benefit and the increased toxicity, should we consider leaving it out and sticking with the standard ABVD. So it was a great debate. I don't think we answered the question here, but I think we had a great overview of the pros and cons and what situations one might consider brentuximab vedotin as part of upfront therapy. So it's been a really great meeting. We had a great audience, a lot of questions, a lot of great participation. And I want to thank you again for joining me today to hear a little bit about our program and the great discussions we had here at Great Debates in Hematologic Malignancies.